Acid-base disorders are a common and often serious problem that is encountered frequently in hospitalized patients. These disorders can lead to significant morbidity and mortality and can initially be intimidating since many patients have a primary disorder and also some degree of compensation. There are 4 primary acid-base disorders: metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. To understand these disorders, we first have to take a step back to the chemistry behind them. So, an acid is defined as a substance that can donate a proton or a hydrogen ion and is represented here by PCO2. This is because most of the acid within the body is present as carbon dioxide. On the other hand, a base is defined as a substance that can accept protons. In this situation, it's represented by bicarb or HCO3-. The degree of acidity of the fluids within the body is then determined by the pH, which is basically a measure of the hydrogen ion concentration. The higher the hydrogen ion concentration, or acid concentration, then the lower the pH. These lab values are typically obtained through the measurement of a blood gas. In normal, healthy adults, the PCO2 is between 35 to 45 millimeters of mercury. The bicarb is 22 to 26 millimoles per liter, and the pH is between 7.35 to 7.45. We'll come back to understanding these disorders in a minute, but first, how do we get these imbalances in the first place? Within the body, there is a regulation of acids and bases to maintain homeostasis, or the concentrations of bicarb and PCO2. The concentrations of acids and bases within the body are maintained through a buffer system, which is made up of bicarb and carbonic acid along with proteins and phosphate. Respiratory regulation, which is responsible for eliminating carbon dioxide or the acid portion. And renal regulation, which is responsible for bicarb elimination or our base. When these systems are no longer able to provide adequate compensation to maintain homeostasis, an acid-base disorder results. So when approaching acid-base disorders, there are 3 helpful things to really keep in mind. First, you want to look at the pH. If the pH is less than 7.4, this means the primary disorder is an acidosis, or too much acid. If, however, the pH is greater than 7.4, this means that the primary disorder is an alkalosis, or too much base. Once you've determined whether you have an acidosis or alkalosis, you then have to figure out, is it respiratory or metabolic? To do this, look at the concentrations of bicarb and PCO2. So first we'll start with acidosis, or a low pH. If you look at the bicarb concentration and see that it is below 22, this indicates that your primary disorder is a metabolic acidosis, or not enough base. With this disorder, there's actually an extra step, aka the third helpful thing to keep in mind. So, anytime you have a metabolic acidosis, you'll need to calculate an anion gap to determine if you have a gap or non-anion gap acidosis. This is done by taking the sodium concentration minus your bicarb plus chloride. Normally, the anion gap is between 3 and 11. Anything greater than 11 is abnormal, and one of the things to keep in mind that you'll go over more in lecture is that if the patient has a low albumin, the anion gap does have to be adjusted. If, on the other hand, the pH is low, so still an acidosis, and the PCO2 is increased, the primary disorder here is a respiratory acidosis, or too much acid. Going back to our pH, on the other side, if you recognize the pH as being increased or having an alkalosis, you can again look at your bicarb and PCO2. If the bicarb is elevated, this indicates you have a metabolic alkalosis or too much base. And if the PCO2 is decreased, this indicates that the primary disorder is a respiratory alkalosis or not enough acid. One simple trick to keep in mind for primary disorders is that with the bicarb and the pH, they will always move in the same direction. So if both of them are decreased, then you know there's a metabolic acidosis. And if both of them are increased, then you know you have a metabolic alkalosis. On the other hand, PCO2 and pH will always be opposites if the primary disorder is respiratory. For example, if the pH is low, the PCO2 will be high. And if the pH is high, the PCO2 will be decreased. With each of these primary disorders, there is also eventually some degree of compensation or change in the levels of the opposite component to help the body return to a desirable pH. Respiratory compensation for primary metabolic disorders occurs much faster than metabolic compensation for respiratory disorders because the body can adjust the rates of your respiration, increasing or decreasing your PCO2, much faster than it can make changes to metabolism or renal elimination, which is responsible for increasing or decreasing the bicarb concentrations. For metabolic acidosis with not enough base, the PCO2 will also decrease, or more PCO2 will be removed. This will help decrease the amount of acid in the body. If the disorder is a metabolic alkalosis, the PCO2 will increase since there is too much base present. This increase will help decrease the pH due to the presence of more acid. Similarly, but at a slower rate, there is also compensation provided from a metabolic standpoint. If there is a respiratory acidosis with too much acid or PCO2, there will be an increase in bicarb to help increase the pH. And finally, if a respiratory alkalosis is present with not enough PCO2, the bicarb will also decrease or be more readily eliminated to help decrease the pH towards normal. The causes behind these disorders and how to correct them will be covered in class, but hopefully this general overview helps these disorders seem less scary and make more sense.